Good evening, everyone. I'm Dr. Ankit Mistry, and on behalf of Intas, it's my honor to welcome you all in a 33rd episode of our Endocrine Talk Show series. Today, we will be discussing on a practical and insightful topic: the endocrine test, when and how. Before we beginning, it's my honor to welcome our moderator for today, Dr. Subhankar Chaudhary sir. Dr. Subhankar Chaudhary sir, currently serving as a director of a department of diabetes and endocrinology at Medica Super Specialties Hospital, Kolkata. With that, now I would like to invite Dr. Subhankar sir to introduce our esteemed panel members. Over to you, sir.
Thank you very much. A very good evening to all of our colleagues from across the country. It's been a wonderful journey since I think the dark days of COVID when this sort of monthly program started. We are on the 33rd episode. We all know as endocrinologists, clinical acumen is extremely important, and many a time it's your clinics that will finally give you the answer. But at the same time, we are also aware that endocrinology, management of endocrinology, involves a whole lot of investigations. And so we are dependent upon the laboratory to a large extent. So, this evening, what we shall try and do and discuss, especially for our physician colleagues, is which are the appropriate endocrine tests and in which conditions we should be ordering them, how to do it. Uh, we shall, of course, deal with common conditions first, maybe diabetes, thyroid, and then go on to less common conditions. But again, within diabetes, we will not deal with the everyday fasting glucose, PP glucose, or even HbA1c. We'll try and go beyond that. And I would advise, I would hope that all our uh, audience, esteemed audience, would put in your questions in the chat box, and I'm sure Dr. Ankit Mistry will hand them over to me so that I can address the questions to our respective panelists. So, as usual, as in every episode, we are blessed, graced with an excellent panel from across India. This evening, we do have five excellent endocrinologists. We have Dr. Mohan Badgandi, who is consultant endocrinologist at the Manipal Hospital in Bangalore. He has a lot of experience in clinical trials, and he is an astute clinician and a very respected endocrinologist. We also have this evening with us Dr. KVS Harikumar, who is a consultant endocrinologist at Magna Clinics, Hyderabad. He has had an excellent academic record. He has had various orations awarded to him, and we are very happy and proud to have him as the Secretary of the Endocrine Society of India.
Thank you, sir.
We have this evening with us Dr. Beena Bansal, who will represent possibly the northern part of India. So she is a consultant endocrinologist at Door to Care Endocrine and Diabetes Clinic, Gurugram. She has had various awards to her name and grants, and she has had a best oral presentation. She has had a prize for IGM awards for excellence in writing in 2012, and she's also a much sought after speaker at various conferences. Next, we have in our team this evening Dr. N.K. Narayanan, who is a consultant endocrinologist at Apollo Hospitals in Chennai. He has contributed to the formulation of the East Anglia Regional Guidelines for the Management of Pituitary Tumors when he was in the UK, and he has various other publications to his name and has been invited to various national and international conferences. Last but not the least, we have Dr. Parthopratim Chakraborty. Can we have his slide as well? Who is a faculty in the Department of Endocrinology at the very prestigious Medical College in Kolkata. He has several publications to his name. He's one of the most, I would say, uh, well-read endocrinologists even across the country. And his research interests are pediatric endocrinology, diabetes in young, adrenal disorders, renal tubular disorders, and something that many of you may not know is why he's deeply interested into wildlife photography, and he is a very expert hand at that. So with this, we complete our introduction of our esteemed panelists, and let us get into the meat of the discussion proper. Once again, for all our colleagues, please put down your questions. We shall try and answer as many of them as possible. So diabetes is our bread and butter for all of us. And we know we need to do so many investigations, partly to assess the glycemia, partly to look for complications. In terms of the assessment of glycemic control, of course, HbA1c has come up in a very big way. We do understand that there could be situations where HbA1c may not give us the appropriate answer or that we are looking for. And there are some tests which are not commonly done. For example, fructosamine is one. So I would first request Dr. Mohan Gandhi, with your vast experience, do you ever advise for fructosamine test? I do advise, I must admit, but if you do advise, when would you advise and how do you interpret the value?
Yeah, thank you very much, Dr. Shubhankar. As you know, glycation of serum proteins, and 90% of it is albumin, and maybe 8 to 10% of it is other proteins. And this gives you a glucose bracket of about 2 to 3 weeks. And it is very useful test when you cannot really rely on a glycated hemoglobin, for example, in hemoglobinopathies, thalassemia variants, or thalassemia minor, major, and renal failure, diabetic kidney disease, all these, and where acute hemolysis is going on, or the patients are on a chronic hemodialysis, and patients are on repeated blood transfusions. But unfortunately, well established, not well standardized. That's why we are not able to do it as a routine test. Maybe in these following conditions, I would request them to do fructosamine. But unfortunately, I have not used more than 4 or 5 times in my last few years, because eventually what happens is that you want to know what is the uh, you know glucose values in a patient in the previous 2 to 3 weeks, if you want to change the therapy, or if you want to assess your therapy. So today we are very happy with CGMS and glucose monitoring, which gives you time in range, time above range, time below range. So it has got its own problems, fructosamide, because the values are dependent on albumin levels. The moment albumin level starts to decrease less than 5 grams, but it's the values of fructosamide as 200 to 285 micromoles per liter. But I don't know what are the various assays that are used, because most labs do not really use the same assay. So this is one of the problems that we have when it comes to talking to the patient or convincing the patient. It is very useful in pregnancy also, where you want to the
Doctor.
short-term glycemia in a patient, they have a control or not, you want to go ahead with that. So these are the few areas which covers fructosamine covers, but unfortunately we are not able to do this test on a routine basis.
Right, exactly. I think all the other panelists would also agree that despite maybe the theoretical indications for use of fructosamine in practice, possibly we don't use it that often, and maybe part of the uh, role played by fructosamine could be taken up now by CGM. So can we go on to CGM, which is continuous glucose monitoring? We do know, I mean, uh, home monitoring of blood glucose is important, and we do advise patients, but many a time patients find it difficult to do so many finger stick in a day. And so CGM has indeed come up in a big way. Can I ask Dr. Narayanan to sort of tell us what is the indication? When would you advise continuous glucose monitoring in type 2 diabetes?
Yeah. Good
And
evening.
if you advise, yes, would it be continuous? I mean, you keep it on for years together, or you do repeat at certain intervals? What is your approach to it?
Good evening, sir. As you rightly said, the CGMS has given another new metric, another new dimension to assess the glycemic control in people with diabetes, especially in type 1 diabetes when we are using in conjunction with a closed loop, but also in type 2 diabetes in certain scenarios when we are stuck as to what is the metric in front of us is telling us. For example, when there is a discrepancy between the HbA1c value and your fasting PP, let's say the fasting is 110, postprandial is 170 consistently, but the HbA1c is showing up as 9.7, it could be a lab error. But assuming that if the lab is correct, then there is something which is happening at other points in time when the sugar levels are not being monitored, the peaks that we are missing. So in that sort of situation, the CGMS would be a helpful tool to assess as to whether they are spiking post-lunch, post-dinner, or in the middle of the night. Sometimes we do come across people who have hypo unawareness when it is really risky and dangerous, especially in elderly when they are living alone, especially with the modern gadgets that we have with CGMS, the modern CGMS that we have, where it is set with alarms, either low or high. And if the sugar levels are dipping down below a certain range, at least it can alert them to say that it is dipping down. Can you correct it? Patients who have significant glucose variability. I mean, glycemic variability is something which we know that has got a greater impact on the long-term micro and macrovascular complications. People who are on intensive insulin regimes when there is a need for frequent monitoring. We know that the fingertip testing, which is flooded with nerve endings, it's quite painful to do the testing so often. And when we are especially changing the regime, changing to a new regime where you want to control it quite rapidly, like for example, a type 2 diabetes poorly controlled, just gotten pregnant, and you want to control it as quickly as possible. In these sort of situations, the CGMS would be a very helpful tool. Sometimes we come across situations where the fasting blood sugar is high. We do not know whether it's a dawn phenomenon where the glucose levels are increasing throughout the night, or whether they are dipping down at middle of the night and then it is increasing. We can ask them to do a 2 a.m. or a 3 a.m. blood sugar to fix between this. The other alternative would be a CGMS. In newly diagnosed diabetes, or in people who are really wanting to know as to what is the impact of the diet and particular lifestyle changes that they are making, exercise, etc. In these sort of situations, again, the CGMS will be a helpful learning tool more for the patients rather than for the physician. It will be a helpful learning tool for them to assess what impact the different types of diet they are adapting is going to have and the different exercise regime. As to how frequently we need to use this, again, as long as the question is answered, let's say if there is a discrepancy between the HbA1c and the fasting PP glucose, we have put it on for 14 days. The typical CGMS lasts for 14 days. We've got an answer as to where it is peaking. And often I use it in a way where in the initial 4 days, I ask them to come back to reassess as to what is happening, where the peak is, where the troughs are. You make a correction to the regime, again, you can reassess after 5 days. So in a 15-day window, we can reassess them at every 5 days or so that you can use it to diagnose as well as to implement or intervene with a new intervention, and to see the impact of the new intervention also. So how long we use is entirely dictated by what is the question that we are trying to answer. Sometimes patients want to use it on a continuous basis. We do have people who are using it on a continuous basis.
Right, and that was a very practical advice as to using the best, making the best use of 14 days CGM by implementing a change and observing what's the impact it had on. So, a question. Let's come to Dr. Hari Kumar. So, for a physician, a busy physician, you may advise a CGM, but CGM comes with a whole lot of pages after pages of data. So what do you do that? I mean, with all that data, and how do you interpret? Could there be a smart way of looking at it, that this is the basic things that you need to do, you need to look at, and how do you interpret?
Yeah, good evening, sir. Some of the things after expanding what Dr. Narayanan has said, whenever I prescribe CGM, one, I always ask them to maintain a diet diary, because unless you have a actual record of what is happening, it is matching with the glucose will give a more better inputs. Some of the patients actually whom I have advised that you should eat roti instead of rice have got a CGM evidence to say vice versa. So those things it help actually. But I get cheesed off when somebody eats a rasgulla and comes with a CGM data. This is how it is going. But those are the settings where you are not supposed to. Okay, number one. Number two, definitely there is enough of data which comes from CGM. But most of the things what we are looking at is time below range is more relevant in a type 1, where unknown hypos or maybe hypo unawareness is what we are more worried about. And time in range, depending on the setting and depending on the age group, is it in a acceptable zone, which we will get through the GMI, which is another indicator in the CGM, which comes, may not be a, actually mimicking the A1C, but it will tell you that where you are likely to lead if you maintain the same way. So some of those things are the key factors what I would look at. Beyond, as sir has rightly said, there will be at least 15-20 pages. You wouldn't actually get hold of much of the things, but say postprandial peaks, how peaks are going on and how can I address it, and the time gap, and do you actually address those things, or you can make a meaningful correction. And that is the graph will give you that, centile graphs will give you, and the time below range, especially in type 1s for the risk of especially nocturnal hypoglycemias, and more or less the average, the GMI as well as the time in range. These are the key things which I look at. Beyond that, I don't actually much, and I would only use it in discrepancy between A1C and SMBG.
And GMI, what exactly does it represent, Dr. Hari?
So GMI is a, it's like what the values have been recorded by the CGM device, converting it into it's a glucose management indicator, which will give you a number matching the A1C, but actually it is the original estimated A1C has been replaced with the term GMI, because the discrepancy of estimated A1C and actual A1C, there's a lot of variation. It gives confusion to the patients. So that is why that estimated A1C is converted to GMI. GMI will give you a place where you will stand actually. And it gives a fair correlation with the A1C.
Right. So we have a question from Dr. Shalini. Maybe Hari, you take it. So how do CGMs work? Are there any downsides to CGMs? Okay. Yeah.
Yeah. How do they work? It is basically the sensor is there in the interstitial fluid. There is some lag period which you need to understand that it is not exactly matching the blood glucose, what you call it. There is some 15-minute window which you need to understand. There are a lot of factors which can actually influence vitamin C, acetyl salicylic acid, phenramine, all those things. Some interfering substances may not give you the correct value. At the lower ends, they are not, the sensitivity of CGM devices are not correct. So, and some of them, depending on what type of CGMs you are using, you may require a calibration with the usage of the capillary glucometers, or some of them are don't require, you only require a factory calibration. But in nutshell, I would say it is a good device, but in doubt, you should go back to your SMBG to rely on to cross check what your CGMs are doing. Don't treat blindly based on your CGMs, and they are not yet recommended even for a intensive care setups where you will obviously use the capillary glucose values as well only.
Right. Thank you. So when we talk of diabetes, of course, we think of polyuria, polydipsia. While diabetes, when we say diabetes, diabetes mellitus is what we talk about. So can we ask Dr. Parthapratim Chakraborty as to how do you evaluate someone who says that I'm passing a lot of urine? How do you evaluate such an individual?
Good evening to all of you. So this is a different form of diabetes, not diabetes mellitus, previously known as diabetes insipidus. Now it's called AVP deficiency or AVP resistance, whatever, depending upon whether it's central diabetes insipidus or nephrogenic diabetes insipidus. So can we get
So patient comes with a history that he or she is passing excess amount of urine. So how do you evaluate such an individual?
in the algorithm, we first need to confirm the diagnosis of polyuria, which is defined as in adults and in older children, about 50 ml per kg per day of urine output. The values are somewhat different in infants. In newborn, it's in the infancy, it's around 150 ml per kg per day or 2 liter per meter square. So if that amount of urine is being passed, then we call it polyuria. So the diagnosis of polyuria needs to be confirmed first, because there are different reasons. For an example, in elderly individuals with lower urinary tract symptoms, they may complain of polyuria, which may not be in the true sense polyuria. So the diagnosis must be made at the very first visit that the patient is having polyuria. So before diving into the algorithms, the best way to differentiate or to exclude osmotic polyuria, mainly diabetes mellitus, to check a blood or urine glucose. Once that has been excluded, then hypokalemia and hypercalcemia should be excluded first, because these are the two common etiologies of nephrogenic diabetes insipidus, and we have seen patients with hypokalemia, secondary to renal tubular acidosis presenting with polyuria. So that part has to be excluded first. Once osmotic diuresis in diabetes mellitus, hypokalemia and hypercalcemia has been reliably excluded in a patient with polyuria, then we have to dive deep into the algorithm protocol of diabetes insipidus.
Right. So someone with polyuria, first you make sure that that's true polyuria, and then you exclude mellitus first, diabetes mellitus, exclude low potassium or high calcium, and then maybe delve into evaluation for AVP deficiency. Excellent. So we haven't got any more questions in the chat box, so maybe we continue our discussion. So from diabetes, let us go into thyroid. Again, a very common condition. So can I ask Dr. Pina, everyone advises a thyroid function test. So does it matter when you do the test? The patient walks into your clinic in the evening and you have the facility. So does it matter whether you do the test in the evening or in the morning, whether it's fasting is essential or not? And this is a very practical question that patients and, of course, physicians also have to face.
So, like any other hormone, like there is a circadian rhythm for thyroid hormone. The hypothalamic pituitary thyroid axis does have a rhythm where the value of TSH especially is lowest early in the morning, 2 a.m. to 4 a.m. And then it is lowest in the evening and highest in the morning. And but most of the time in a euthyroid patient, it would still vary within a normal range. However, if we want to properly kind of follow up the values from one time to another, it's a good idea to check it at the same time, because there is a 20% variation in the results. Very severely hypothyroid patients, it won't matter because the variation would not lead to any clinical significant difference. For subclinical hypothyroid patients, of course, it would make a small difference, and the decisions may change towards this side, treat or not treat, kind of. So early morning sampling is advisable. For patients who are already on medication, how much that would make a difference? I mean, sometimes if it's really necessary, we can go ahead. I mean, but still, I usually ask them to do it in the morning. The second important question most people would ask, whether we should do it fasting, whether we should have the tablet that day. So again, there is some variation in TSH. After eating, there is a dip in TSH, and therefore patients prefer, I mean, it's preferable to do it fasting. Again, the value is not clinically significant. So there is no consensus that you have to do it fasting across guidelines, but it's, if they ask this question, I would say, okay, do it fasting because there is some
Preferable, right?
preferable.
Right.
Taking the medicine, not taking the medicine would change T4 level, of course, but TSH would not be very much affected by missing the tablet on that day and doing it after, like taking the tablet after the test. So TSH doesn't change with that.
So what is your advice? What is your advice?
Preferably, if you're doing T4 and TSH, do it in the fasting state. Morning would be better. Or every time doing it at the same time is what is required. And take the tablet after the test if you're also doing T4
Right.
along with it.
And I think, I mean, endocrinologists tend to differ amongst each other. So on this point, I suppose we are all agreed. Yeah.
These are not very hard. Like there is that soft thing you can always, because we understand their nuances.
Yes. Yeah, sure. Right. So when someone thinks of a thyroid function test, I mean, of course, you do see prescriptions written, advice T1, T2, T3, T4, everything. So can I ask Dr. Hari, when you think of doing a thyroid function test, what test should you advise? Or what would you advise most of the time?
Most of the times, for diagnosing a thyroid disorders, is simple. Total T3, total T4, TSH would be good enough for most of the patients. If you have to diagnose either a hypothyroid or a hyperthyroid, number one. During follow-up, depending on the case, you can just follow it up with TSH. That should be more or less enough. I'm talking about majority of patients, number one. Number two, free thyroid hormones, most of the people would jump on to, because actually most guidelines are based on free thyroid hormone levels. But remember, those are the ones which are estimated by the LCMS, not by the conventional, the ELISA techniques, what we use. So it's like if you are estimating a total T4 versus a free T4, if I have to give a comparison, total T4 is like estimating a basketball, and free T4 is like a golf ball. So you tend to miss out a lot of things. You tend to have a lot of variations whenever you're looking at such small quantity of hormones in the blood. So preferable to use total T4 in most of the settings, and TSH will give the best possible way. Another important thing to look at is T4 slightly low, TSH slightly high do not make it a primary hypothyroidism. There is something known as a log linear relation between these two. So if the clinical profile and the biochemical profile is not matching, go deep into the history, go deep into the examination, and maybe repeat to find out some central hypothyroidism also, which can come with the similar spectrum. Because if you start inadvertently a full dose of levothyroxine in such setting with a underlying adrenal insufficiency as well, we will cause more crisis rather than actually causing any benefit to the patient. By and large, in all settings, rely on thyroid total hormones. The only setting where TSH is not to be used is somebody who is operated pituitary earlier. Their TSH has got not much role to play. And free thyroid hormones are recommended in pregnancy, but I rely more on the total hormone rather than free hormone.
Okay, so can we come directly to pregnancy and ask Dr. Beena as to how to evaluate thyroid function in pregnancy? Is it different?
So there are a lot of hormonal changes which are happening in pregnancy, starting from the first 3 months or the first trimester. There is surge in HCG, which would lead to a low TSH, because that would itself cause stimulation of the thyroid gland. So one change which we see is that initial 3 months, there may be a dip in TSH, which is completely a normal pregnancy-induced, HCG-induced thyrotoxicosis, not to be treated. That's the commonest referral we usually get. That has to be carefully differentiated from hyperthyroidism. So low TSH in the first trimester may happen because of high HCG. The second common change which we see, the second thing which happens in pregnancy is because of high estrogen level, there is increased thyroid binding globulin, and therefore there is increase in T3 and T4 levels. So the T3 and T4 levels should be high, especially if usually the normal values are reported like a non-pregnant normal values. So 1.5 times of normal should be the T3, T4, and hence sometimes free T3, free T4 if done properly, proper assays, as Dr. Hari already said, which is not usually the case. So T3, T4 are supposed to go high in a normal pregnancy. Again, that because there have been cases where they are treated like hyperthyroidism. Again, that is not hyperthyroidism. That is a normal pregnancy-induced variation. So these are the two important changes that happen. I think
Yeah. So
there are some iodine requirement changes, but I think we'll leave that.
Yeah. No, so theoretically, free T4 would be
Better.
the test to do in pregnancy.
Yes.
But guidelines do suggest that you use total T4. And of course, as you said, try and interpret it differently. Maybe 1.5 times, beyond 1.5 times should be considered as abnormal. And then we have a question from Dr. Shushma. Should free thyroxine index still be used in pregnancy? Maybe we take it as free thyroxine or free thyroxine index, or should we rely on trimester-specific reference ranges? So what is the issue here? Trimester-specific reference range.
So, I mean, the data used for trimester-specific reference range is one of the important issues, I would say. I think, I mean, the general guidelines are there are trimester-specific TSH ranges. There are some Indian data on the TSH and T3 and T4 values. I have not been using those, or the assay generated, the ones which we commercially get. They are like, they come with the assays which they are used. So I don't usually use those reference ranges specifically. So in general, 1.5 times the normal T3, T4, I mean the non-pregnant T3, T4. I don't know whether everyone uses trimester-specific T3, T4 values or...
What about TSH, Dr. Partho? So how would you interpret the TSH in pregnancy? Dr. Partho.
Sir, as of now, if we look at the recent data, the trimester-specific references, there is somewhat rise in the recent data in TSH values. Initially, we used to have cutoffs like in first trimester 0.1 to 2.5, in second trimester 0.2 to 2.5, and in third trimester 0.3 to 3. But as of now, from our institute also, there are some publication regarding the trimester-specific TSH value. And it's now known that it's up to 4 is normal. In pregnancy, TSH 4 up to normal. However, while treating a pregnant lady with levothyroxine, I am somewhat confident in keeping the TSH below 2.5. If it's around 3, it's fine, but I tend to keep it around 2.5.
Right.
But up to 4 is normal.
Okay. So we can have so many different issues, of course, related to thyroid function or thyroid evaluation itself. We cannot possibly cover everything, but let's try and talk about thyroid ultrasound. So, Dr. Partho, when would you want a thyroid ultrasound scan to be done? Every patient of thyroid problem?
Not at all. It should not be a routine investigations. It might pick up nodule here and there, but it's not of clinical uses. So there are certain indications in which ultrasounds of the thyroid should be done. Number one, if there is a clinically palpable nodule, a single nodule or a multinodular goiter, if that is clinically palpable, that is number one indication. Number two, if any other imaging modalities pick up a nodule, which is called as thyroid incidentaloma. For an example, a CT scan or a whole body FDG PET scan, if that particular scan picks up a nodule, particularly a FDG scan, if it picks up a nodule, that nodule needs to be evaluated by ultrasonography, because ultrasonography of the thyroid is a more sensitive and a more reliable marker to rule out malignancy compared to CT scan or FDG PET. And number three, in certain situations where there is a diagnostic dilemma between Graves' disease and subacute thyroiditis, the vascularity may be looked at by doing a Doppler of the ultrasound of the thyroid.
Okay.
So these are the three or four indications in which ultrasound of the thyroid should be done.
Right. So any patient, even with a goiter, with diffuse goiter, need not be evaluated
Yes.
with the thyroid ultrasound. So we come to the other part. Maybe Dr. Narayan, and you can help sort of elucidate this. What would be the indications for fine needle aspiration of the cytology of the thyroid, FNAC of the thyroid?
Right. So when we talk about the thyroid FNAC, not every single nodule needs an FNAC. That's the first thing to remember. The nodule characteristics are often more important than the size alone. And we do have classification system when an ultrasound is actually done. Like for breast, we say BIRADS classification. For thyroid, we have ThyRADS classification going from 1 to 5, 1 being the least chance of malignancy and 5 being harboring a higher chance of malignancy. And various characteristics are looked into: the size of the nodule itself, the echogenicity, isoechoic versus hypoechoic carrying a higher chances of malignancy, the regularity of the margins, the presence of microcalcifications. Likewise, many parameters are taken into account, and therefore it is also very subjective depending on who is doing the ultrasound. That somebody who may classify this as ThyRADS 2, another person may classify it as ThyRADS 3. So it's not a hard and fast dictum. As long as you know the sonologist who is doing it, confident about it, then we can go by this. But in general, the ThyRADS 1 and 2 carry a very low risk of malignancy. They do not need an immediate FNAC. Maybe a follow-up would be sufficient. ThyRADS 3, more than 2.5 centimeter, ThyRADS 4 more than 1.5 centimeter, and a ThyRADS 5, which carries the highest risk of malignancy. If the size is more than 1 centimeter, then an FNAC is warranted. But this is based only on the ultrasound characteristics. There are also other clinical parameters which we need to take into account. For example, if the person says in a long-standing MNG, doctor, one of this nodule is just growing very soon. I noticed that this is getting bigger and bigger very rapidly. So then definitely that needs an FNAC. The family history and past medical history also needs to be taken into account. Somebody who has had a head and neck irradiation, we know that there is a higher chance of them developing malignancy. If there is a family history of MEN too, for example, then there is a chance of them having a medullary thyroid CA. Somebody who's got a thyroid nodule and an elevated calcitonin, doesn't matter what the ultrasound characteristics are showing, generally their medullary thyroid cancers are very vascular on an ultrasound. Even if they are not able to pick it up, if there is an elevated calcitonin with a nodule which is palpable, or if there are any other signs of malignancy, let's say somebody who's got a thyroid swelling, a nodule or a swelling, they present with hoarseness of voice. The nodule is very fixed and hard to palpate. It's not moving. They've got a vocal cord palsy. So all this history, the clinical parameters, then the sonology, all these three have to be taken into account to decide which one of these nodules need an FNAC.
Right. A quick one, maybe Dr. Partho, what Dr. Arya wants to know, what are the common changes in lipid profile in thyroid dysfunction?
So it depends upon whether we are dealing with hypothyroidism or hyperthyroidism. Having said that, a gross derangement in lipid function happens only in grossly hypothyroid or grossly hyperthyroid patients. That is number one. We see elevated cholesterols, both LDL cholesterols, HDL cholesterol, total cholesterol, along with high triglycerides in untreated, severe, uncontrolled hypothyroidism. And the reverse happens in hyperthyroidism. The cholesterol levels are low. There is not much difference in the triglyceride level, but once again, uncontrolled severe thyrotoxicosis can give rise to low cholesterol.
Right, right. So we all know that thyroid dysfunction quite commonly is because of underlying autoimmune disease, and there are various antibody tests that are done. So I would request Dr. Mohan Badkandi to throw light on when do you advise and which thyroid antibody test to be done. we talked about the hormone test, T3, T4, TSH, ultrasound, FNSA, now about thyroid antibodies.
So we try to establish or support the diagnosis of primary hypothyroidism or primary hyperthyroidism like thyrotoxicosis or Graves' disease, Hashimoto's thyroiditis. Any of these, if you want to establish the background pathology of autoimmunity, then one needs to do the thyroid antibodies. There are 3 or 4 types of thyroid antibodies. One of them is a TPO, which is very commonly observed in primary hypothyroidism of autoimmune origin, but majority of the patients that we see in India or in our population, they are majority are thyroprevic, not autoimmune, but we do see autoimmune thyroiditis, autoimmune thyroid deficiency, as well as Hashimoto's thyroiditis, where the TPO antibodies in most of these patients are highly positive. And these antibodies not only support the diagnosis, and they're very important in predicting the outcome, whether the patient needs lifelong therapy or patient needs to be followed up regularly, whether there are any other issues happening, or whether there are other autoimmune disorders likely to come up in the future life. Say, for example, type 1 is common in type 1 diabetes is common in people who have autoimmune thyroid deficiency, as well as sometimes the non-organ specific antibodies. But all these, cluster around either a generalized vitiligo or individual family history. So TPO is one of the antibodies that we commonly do it in our population. And again, when we see a patient with the Graves' disease or thyrotoxicosis, we would like to do thyroid receptor antibodies, which are either stimulatory or destructive or damaging. And those antibodies are also done commonly in most of the labs. But these facilities are only available, I suppose, in bigger metros and bigger institutions. And commonly in a district place or a smaller places, antibodies may not be available, where the clinician will have to depend mainly on the historical data as well as the clinical, observation. Say, for example, in a patient with, say, Graves' disease, one who has diffuse goiter and elevated levels of T3, T4, and suppressed TSH, and some amount of, say, skin changes or eye changes, we presume that the diagnosis is Graves' disease. We may not really wait and watch for the antibody levels. But if the antibody levels are available, one can do the levels and start treating the patient. And when the patient starts responding, or when you complete the treatment, also you can do the levels so that recurrence can be predicted or relapse can be predicted, where again you can use either a second dose of antithyroid drugs, or you can have a conversation with the patient and discuss about the radioiodine therapy in these patients. And the last antibody is the thyroglobulin antibody, which is normally done in cases of papillary CA, where we normally follow up the patients with levels of thyroglobulin when we stop the thyroxine therapy for 2 to 3 weeks, or sometimes we repeat the scans using thyrogen. Whenever we want to do the thyroglobulin in these patients, the nuclear medicine people always demand that when you raise the TSH, you get the thyroglobulin done, and also you do the thyroglobulin antibodies, because that gives them a more confidence in assessing the real value of thyroglobulin while deciding to do the repeat iodine ablation or give a smaller dose, higher dose, all these things. And again, to mention here that even the TPO antibody levels or the TRAB antibody levels always give you the severity of the disease or the severity of recurrence or how long is the treatment required. So if you can monitor all these things, it is very useful in the diagnosis, supporting the diagnosis and managing or monitoring the therapeutic outcome.
Right. So the antibodies, of course, when someone has got thyrotoxicosis, maybe presence of this TSH receptor antibody may help us establish a diagnosis of
Yeah.
Graves' disease versus maybe a thyroiditis leading to a transient thyrotoxicosis. Right. And of
Yeah.
course, the anti-TPO antibody could support a diagnosis of what Hashimoto's thyroiditis, but many
Especially
time
as Dr. Bansal said, in pregnancy, when you have, or say pre-pregnancy or during pregnancy, when you have a dilemma of TSH values which are not giving you the, enough confidence about diagnosing hypothyroidism or hyperthyroidism, you
So,
could depend on the antibody levels as well, where it is very useful.
yeah, presence of a positive antibody may
Yeah.
reinforce our decision to treat with
Yeah.
thyroxine. Right. So maybe a quick one, whoever, Dr. Schumann wants to know, how do thyroid antibody profiles differ in Hashimoto's thyroiditis versus Graves' disease? Dr. Narayanan, quick one, and then we move on.
So as think the previous speaker also alluded to this, the TSH receptor antibodies are more useful when we are suspecting a hyperthyroidism, i.e. Graves' disease. In typical Hashimoto's, we often look at the TPO and the anti-thyroglobulin antibody, but it is no dictum. Even in Graves' disease, your antithyroid antibodies, like your TPO and other things, can be elevated. So it's not a dictum that this will be Hashimoto's, that will be. And we do have other conditions where we say about, we talk about blocking and stimulating antibodies. Although rare, this can happen. The thyroid stimulating immunoglobulins can sometimes stimulate the receptors, sometimes block the receptors. So all it tells you is this patient is prone for autoimmunity, has got an autoimmune thyroid disease, and we do see people who are flipping back and forth between hyper and hypo because of these blocking and stimulating antibodies.
Right. So that does happen, though maybe not as often, but it does happen.
Yeah.
So
Yep.
we quickly maybe touch upon anti-thyroid drug treatment. And can we ask Dr. Bida Bansal, as someone who's been started on anti-thyroid drugs, maybe carbimazole or methimazole or whatever, how do you monitor these patients?
Yeah. So, of course, initially when we initiate this, although the side effects which we are most worried about, the severe side effects of counts going down, low TLC, leukopenia, etc., and very commonly rashes, etc., we can inform the patient that these are the side effects one may want to observe for if they have rashes, and or if they have some sore throat, painful swallowing, etc., they need to come back. I mean, that is the best way of following the patient. And most of the time, the side effects appear only in the initial phases. It has been reported that the first year of treatment, if there is no side effect, the chances later are very less. So when we initiate the drug, especially in high doses, it's a good idea to inform the patient that they need to come back. And if there are these symptoms, then we can check CBC. If they have symptoms of liver dysfunction, then we can check liver function. There is no routine recommendation to do that because hyperthyroidism itself may impair liver function, for example, and sometimes on treatment that improves. But if we do not have a baseline value, we may misinterpret a later high value. Suppose it's just because it is carrying forward from the initial thing, because that happens very often. So maybe we can check at the onset sometimes to establish that to begin with it is high, or there is no need to routinely test anything. Just clinically monitor the patient for side effects, inform the patient to come back to us if they have rashes, if they had pain, if they have painful swallowing. Maybe a written instruction on the file is good enough.
Right. So that's about the side effects. What about the effects? How do you assess the
Effects.
effect?
Yes,
So
sorry.
when do you test and what test
Yes.
do you advise?
So hyperthyroidism is a condition. We usually start with high doses of antithyroid drugs, which usually are tapered over a period of time if the patient is good enough to respond nicely to the drugs. So the most important thing to tell the patient on the first visit itself that they need to monitor maybe monthly, initially monthly for first 3 months. Then 2 to 3 monthly for next 3 to 6 months. That's the minimum frequency which is mostly required for patients because the treatment needs to be
And
titrated.
what test do you advise?
We advise T3, T4. TSH takes time to come up. Although we'll advise T3, T4, TSH, a low TSH doesn't need to be treated because initial first to 6 months, if the TSH is going high very quickly, it is usually at the expense of T3, T4 going low very quickly, and the doses need to come down. So monitor T3, T4, follow that carefully. TSH will take time to rise. So if T3, T4 are falling very quickly, you still need to reduce the dose of antithyroid drug, even if the TSH is suppressed, because I think that
Right,
also
yeah.
happens very often. So T3, T4, TSH once a month for first 3 months, once in 2 months for next 4 months or 6 months, and then 3 monthly. And then even after, suppose after a year or 1.5 years, the medications have been stopped, we will need to monitor thereafter also, initially 6 monthly and then annually for life. TSH receptor antibody monitoring, if it is financially feasible, is also recommended because, especially nowadays, there is a change in pattern, or there is a discussion on how long-term antithyroid drug is being used in many patients, and when to stop the drug is very much dependent on the TSH receptor antibody when we plan to discontinue the drug. And initially also at the onset, TSH receptor antibody gives some prognostic information whether the patient will be able, that is
Right,
one of the
yeah.
factors which helps us decide how long the antithyroid drug will continue or not. So TSH receptor antibody is another test we usually do if possible, especially in
Right,
pregnancy.
yeah,
That's an
yeah.
important test to do.
I do not know the practice of the others. Almost invariably, I do not advise TSH at the initial follow-up because invariably patients will come up and say the TSH is still low, so what are you treating? It's not, the drug is not working. So usually I defer it till at least 6 months after I've started treatment. Right. So we have a quick question. Dr. Ganeshan wants to know, how does low vitamin D or does low vitamin D have any effect on thyroid function? Low vitamin D is again everywhere. So does it affect? Anyone likes to take this question? Hari, brave one.
The only thing is vitamin D is supposed to be the solution for all problems of life. And if at all, I can say some amount of vitamin D deficiency will lead to increase in the immune mediated disorders. If you are looking at some of these autoimmune, that is only the Hashimoto's or Graves spectrum, some increase in the worsening of symptoms are reported. There are some reports about increase in the eye score, I mean the orbitopathy in scores with a vitamin D deficiency, but
Acha.
these are all more of the correlation studies, not the causative studies. So by and
Right.
large, I would just advise that you just replace vitamin D, assume that it will be good, but there is no proof that it will do good.
Right. Thank you. So we come to a very important area, which is about hypertension, and it's amongst the endocrine causes of hypertension, primary aldosterone excess from the adrenal gland, adrenal cortex, is known to be an important cause of secondary hypertension. And however, in course of time, with evaluation of more number of people, it does appear that even amongst those people who are going around labeled as essential hypertension, a significant number may have primary aldosteronism, which is an eminently curable form of hypertension. So, can we have Dr. Mohan Badkandi to shed some light on whether you feel that everyone with hypertension should be screened, and then if you decide to screen, how do you screen?
It is, it's as high as 10% of all your hypertensive patients are known to have primary aldosteronism. So I think somebody who falls in the age group of less than 40 years with the family history of either primary aldosterone Conn syndrome or a secondary hypertension, or people who have had hypertension and hypokalemia, hypertension and atrial fibrillation, or hypertension and structural abnormalities in the heart, or patients with hypertension and very early in life with LV dysfunction. these are the patients, I think, also some atypical symptoms like sweating, migraine, and arrhythmias in younger patients. I would go ahead and monitor these patients or screen these patients for primary hyperaldosteronism. And I will definitely say I would not screen everybody for this, but definitely those who are below 50 or 40 years of age, young patients with these symptoms, I will definitely screen them. And definitely it is
And maybe the ones with so-called
family history.
severe hypertension
Resistant
requiring, yeah,
hypertension
yeah,
is another group of patients where we come to more than 3 antihypertensive drugs who have been using, and the patient is not responding. We call it resistant hypertension and call them back into your OPD and screen them for primary aldosteronism, or somebody who is not at all responding to your antihypertensive regimen that you are doing. So these are the patients who I think you should really screen because it is a treatable. And today, what most societies recommend is that we are really missing, PA in our patients, and these go unnoticed and come up later when they are already complicated and have had a, long-term complications of hypertension or a renal damage or cardiovascular damage, stroke. So these are the problems that we
right.
are facing in primary hyperaldosteronism.
So how do you screen for primary aldosteronism?
Now, the screening is, of course, we starts with your, taking a clinical history as well as making sure that you have recorded the hypertension and medical
In terms
history,
of
and then you
tests, yeah,
start do a primary, renin levels and aldosterone levels, and find out the ratio, and the recommended society ratios are available. And then you can also look at those who have got, you can do uh, uh, renin secretion. Most of the time we
so
depend on the
aldosterone
PA
renin,
ratios. That is what
right.
ultimate diagnosis is confirmed by that.
Quick one from Partho. So a patient with maybe a common scenario where we suspect primary aldosteronism will be someone who is already on multiple antihypertensive drugs. So does it matter as to what drug the person is in terms of evaluation? Do we need to change
So
any drugs?
there are drugs which are known to cause interference while evaluating any patient with primary hyperaldosteronism with PAPR. So of which the most important are the spironolactone,
But
the pilocorticoid
okay, yeah.
antagonist, and the diuretics. So it is said that these drugs need to be stopped for at least 4 weeks. Having said that, if the test has already been done and the patient has suppressed PRA, so we can go forward with the whatever reports we have because it won't interfere with the interpretation. The only drugs which are known to elevate PRA are the beta blockers and the centrally acting alpha 2 agonists. So
Beta blockers will decrease renin.
The
Yeah,
only drugs known to suppress PRA is the beta blockers
Beta
and the
blockers.
acting alpha 2 agonist. So that may come as falsely positive. Most of the drugs are known to cause false negative results. So having said that, as I have said earlier, as long as the PRA is suppressed, we can proceed with the whatever reports we have as the PA and PR.
right. So maybe we have to gradually come to the end of this very interesting course of discussion. We still need to look at common scenarios like hyponatremia, low serum sodium, which may have multiple etiologies. Evaluation may involve a whole lot of things, but can we have some quick guidance from Dr. Narayanan as to how should we evaluate someone who has come with low sodium level?
Yes, sir. So the first thing to confirm whether this is a true hyponatremia or a pseudo hyponatremia, suffice to say, most of the modern assays do not have interference. They do give the correct sodium levels. The SJS assays do have a problem with the pseudo hyponatremia. When I say pseudo hyponatremia, there is increased level of osmolar substances due to either lipids like triglycerides, or it could be high levels of protein like in a multiple myeloma. Therefore, The one test which will help in this context would be a serum osmolality. If the sodium is low and the serum osmolality is also low, that is a true hyponatremia. If the serum osmolality is normal or elevated, then we are dealing with some pseudo hyponatremia where the low sodium is related to something else. Assuming it's a true hyponatremia, or true hyponatremia, then the clinical assessment starts with the volemic status. So the most important two differentiating factors I would look at is, one is whether the patient is dehydrated clinically, i.e. hypovolemic hyponatremia, or they are volume overloaded. The euvolemia is very difficult to assess. As long as clinically we assess these two things. The hypovolemic status can be due to GI losses, nephrogenic losses, many other losses. You just replace the saline that it is being lost, the sodium will come back to normal. If it's a hypervolemic, then treat the underlying cause. It could be congestive cardiac failure, CLD patients who are having a third space collection, etc. Then treat the underlying cause. Often they have a chronic mild to moderate hyponatremia. Often they don't drift into a severe hyponatremia unless there is a second hit due to some other reason. Once we have ruled out hypovolemic and hypervolemic, then the euvolemic hyponatremia will have other reasons, SADH being the most common thing which we come across. And before we rule out or label them as SADH, we need to rule out that they are euadrenal and euthyroid. These are the two important hormones which can cause hyponatremia, hypothyroidism and hypoadrenalism. After ruling these two things out, then the label comes as SADH. Then again, the management depends on three important factors. What is the degree of hyponatremia? Whether it is like 131, 132 in an elderly who has got a reset osmostat, or it is 120 in a young person who is suddenly dropped the sodium. The second thing is the duration of hyponatremia, whether it's an acute or chronic, because if it's an acute, you can correct it rapidly. Also, less than 48 hours, essentially. If it is more than 48 hours, then it is better it is corrected on a slow basis, not more than 10 to 12 milliequivalents in a given 24 hours time period. Otherwise, you will be precipitating central point in myelinolysis. Although uncommon, it can happen. The third aspect is the symptoms. Somebody who has got a chronic hyponatremia, sodium of 127, 128, they may not have much symptoms at all. Therefore, the correction can also be gradual. If somebody is presenting with altered sensorium, neurological deficits, then obviously this needs a more urgent attention.
Right. Great. And would there be any role for urinary sodium estimation?
So that comes whether to see whether there is a nephrogenic loss. When there is a nephrogenic loss, the urine sodium is going to be high. When there is a non-nephrogenic loss, like a GI loss, then the urine sodium is typically less than 10 milliequivalents, which suggests that the kidney is trying to conserve the sodium what is available.
Right. Let's try and cover a few more common conditions in the next maybe 15 minutes or so. So one is short stature. So how do we evaluate for, or what are the screening tests if parents bring along a child and say that my child is not growing well? So Dr. Partha Chakraborty, what would be the screening tests? Of course, you need to do measurements and all that. So quickly.
The commonest cause of short stature is constitutional delay in growth and puberty and familial short stature. So many of them may not require any investigations if the target height and the measured height is not that different. So once the familial short stature has been ruled out, then the common etiologies like chronic malnutrition, chronic systemic illness, those things are needs to be ruled out first. So once that part has been done, then the best investigation would be a thyroid function test, primary hypothyroid to be more specific, FT4 TSH for all. In girls, a karyotype to rule out Turner syndrome. And if those are negatives, then IGF-1, the insulin-like growth factor 1, to look for growth hormone deficiency, which once again is a relatively rare cause of short stature.
Right, so that's a quick one. Yes. What about obesity? Again, everyone is obese these days. So how would you evaluate someone with obesity? And of course, many of the patients who are obese would already come with a thyroid function test. So how important is a thyroid function test in the evaluation of obesity? Dr. Mohan, please.
It's not really very important test, but at the same time, I would not like to say that it is not required. It is necessary while investigating your obese patients because it gives rise to about, say, plus minus 5 kg weight loss when you start the therapy, because they lose myxedemastousness water and they lose some weight. But having said that, there are also people who gain weight when you start them on a thyroxine treatment. So this pattern we're not able to understand why in some people they gain weight, why some people lose weight. People who are myxedematos do lose weight. But when we are investigating a patient of simple obesity, I think it comes up as one of the thermogenic hormones levels that you must establish that it is normal or not normal. If it is high, because the patient definitely needs uh, thyroxine replacement in order to improve the activity, reduce the lethargy, tiredness, all those symptoms, and improve the menstrual cycles in a female, and also improve the the mental activity and the mood changes.
I'm sure this refers to those with overt hypothyroidism, significant hypothyroidism, not the subclinical hypothyroid. Those individuals may not benefit much from thyroxine.
May not benefit, yes,
And
may not benefit much from thyroxine replacement, but those who benefit are definitely going to benefit in a bigger way. So if the patient falls in the subclinical hypothyroidism, may not. But at the same time, hypothyroid patients or simple obesity patients.
So thyroid function test is one that you do. What
Yeah.
else would you do for
I would
evaluation?
like to basically see more before going into biochemical tests. One important thing that I would like to do in an obese patient, one who has come to me, is I would like to ask him what was his best weight and when has he gained weight. Is it a gradual or is it a very sudden recently? And are there any comorbidities associated with that, which also need to be addressed? And what is the goal? How much patient wants to lose? Because we may have in mind 25 kg, but patient may want only 8 to 10 kg weight loss. So there has to be a conversation between the patient and the doctor and come to a terms where the patient is happy to lose 8 kg, 10 kg, but the doctor wants to give him 25 kg weight loss. So that is not possible. So this is what is very important. So I think we need to do serum cortisol or overnight dexamethasone suppression test. Those are the tests that we would like to do. But more than that, I would prefer to investigate them for the cardiovascular risk rather than this obstructive sleep apnea, osteoarthritis, and then also their lipid parameters, and then along with the thyroid. So
Right.
these are the things then important. And even I would also send them across to clinical psychologists to give them a good assessment and convince them what is needed, how much they need to
Right.
lose, and how much they to improve the quality of life.
Right, absolutely. So for obese individuals, we of course need to try and assess if there is an underlying cause and evaluate for that. And of course, the effects of obesity, cardiovascular, and so on, the glycemic status, the metabolic status, all these need to be evaluated. Right. So maybe we'll have time for a little more time. So can we ask Dr. Partha Chakraborty about infertility in a man? What are the tests that would be
But the
advised?
commonest etiology of in male, sir?
Yes,
What's your
male,
question? Yeah, so
male,
commonest
male.
etiology in male is probably idiopathic. So once again, it starts with a clinical examination simply because Klinefelter syndrome is one of the underdiagnosed conditions of male hypogonadism and male infertility. So we shall start with evaluating or examining the testes first and presence or absence of any gynecomastia. If the testes are firm, shorty, that is probability of Klinefelter syndrome is there. Now we have seen patients with 46XX male, SRY positive 46XX male, simulating Klinefelter syndrome. And in that series, all of them were diagnosed, picked up from diabetes OPD, presenting with primary infertility. So these are the conditions we need to know. So once the clinical examination is normal, then we need to look at the seminogram and the FSH value to be more specific. So a fructose level might give us an idea about any obstructive
Means fructose in the semen. Yeah.
seminal fluid fructose level might give us an idea about obstructive etiology of infertility. And the FSH is, if it is more than 8 in males, that suggests some amount of seminiferous tubule dysfunction. So if testicular FSH level is more than 8, then we possibly need to rule out YQ microdeletion. If FSH level is normal, then we may diagnose, and the fructose level is also normal, then this is probably a case of idiopathic infertility.
Right. So semen analysis, FSH,
FSH and clinical examination.
Yeah, clinical, of course. Right. And what about female infertility, Dr. Beena?
Yeah. So in
And
female,
maybe
yeah.
we are into the rapid fire round,
Yeah,
possibly.
so quickly we'll do TSH, we'll do prolactin, because of course after a good menstrual history, for ovulatory dysfunction at 21st day, progesterone usually is helpful, apart from follicular monitoring on ultrasound. FSH, LH, at least to rule out hypothalamic versus primary versus secondary hypogonadism. That is for all the ovulatory causes. To look at any blockages in the passage, HSG and hysteroscopy. I think this would cover most of it. Apart from that, there would be rare causes of, even despite all of this, there may be unknown causes which are difficult to diagnose, the antibody, etc.
Right. So, Dr. Hari Kumar, a patient presents with Cushingoid features. So how do you evaluate this individual? Will the physician refer straight away to Dr. Hari Kumar, or he or she could also do some tests and then send to Dr. Hari Kumar?
So the first and foremost, just learn about the discriminant features. That is the most important thing for Cushing's. Proximal myopathy, easy bruisability, violaceous striae. Some of these things are hard features to suggest an underlying Cushing's, number one. Number two, always, top 3 diagnosis is exogenous. So just do a 8 a.m. cortisol. That will clinch the diagnosis most of the times. If you are suspecting Cushing's...
So how does it clinch?
8 a.m. cortisol, if it is suppressed, that means it is a exogenous Cushing's. It will just straight away. So you need to, even though patient may deny that they are taking any tablet, they may be taking some nutritious powders, they may be applying some balms, they may be taking some potions. So all those things you have to go back to history when your 8 a.m. cortisol is low. If 8 a.m. cortisol is normal or elevated in a suspected Cushing's, please find a nearest endocrinologist before you do anything else. That will be the best, actually. Conventionally, we do a ONDST or maybe a cortisol, late night salivary cortisol, other things, but all of them have got ifs and buts and sensitivity, specificity variation. But in a suspected Cushing's, if you have ruled out exogenous, please look for a endocrinologist who will be able to help you, because most of us also have faced music in this patient. So I'm sure everybody will face music in Cushing's.
Right, thanks. So once again, our audience, if there are any other burning topics, questions that you want to raise before our expert panel, please do so. We should be winding up soon. But before that, I'd like to request Dr. Narayanan to highlight the role of bone mineral density evaluation, BMD, and DEXA. When should it be advised?
So definitely in people who have got risk factors, like for example, a postmenopausal women, or who has got premature ovarian failure, a man with hypogonadism, people who have been on steroids.
Sorry, Dr. Naran. So every menopausal woman should undergo BMD?
No, I'm just saying these are the risk factors we need to look out for. But let's say, for example, if this person has had a fragility fracture at any age above the age of 50, then obviously there is a history. Mother who has had a fractured neck of femur in a postmenopausal woman, definitely this person would be screened for with a DEXA bone scan. But these are the risk factors we need to look out for. People who have been on, like, for example, exogenous steroids for more than 3 years. Again, this is a risk factor for them to have a low BMD. People who have eating disorders, underweight, low BMI of less than 19. All these individuals are at risk of developing an osteoporosis.
Right. So BMD is also a test that maybe we should be doing more often. We should be having more facilities for doing this test as well, because osteoporosis is also sort of a silent, may not be a killer in that sense, but it also does entail a lot of not only morbidity but even mortality. So that's something that we should also be looking out for and evaluating and treating as much as possible. So I think we had a fair bit of discussion covering various aspects of endocrinology. Of course, we can never cover all the aspects, and I'm really thankful to all our panelists, Dr. Mohan Bhatgandhi, Dr. Beena Bansal, Dr. Hari Kumar, Dr. Narayanan, Dr. Partha Chakraborty, for the insightful comments, and of course to our audience who have kept us on our toes with sharp questions and comments, which kept the program alive and interesting. So with these few words, I would like to hand over to the INTAS team for the final comments.
Yeah. Thank you, sir. First of all, I would like to thank you, Dr. Subhankar Chaudhary, sir, for his excellent moderation for this 33 endocrine talk show. So we are forever grateful to Dr. Subhankar for he's sparing every month he's sparing his time for continuing this show. Thank you, sir. Thanks a lot from Zenith Intas team. I would also like to give my heartfelt thanks to all the faculties who have joined today, starting from Dr. Beena Bansal, Dr. N.K. Narayan, Dr. Mohan Bhatgandhi, Dr. K.V.S. Harikumar, and Dr. Partha Pratim Chakrabarti. Thanks a lot, everyone, for joining us today. And with this, I would like to close the program for today's session. Thank you, sir.
Thank you,
And a
Demetrius.
big,
Thank
big,
you.
big,
Thank you.
big,
Thank you all.
big,
Good night,
Thank
everybody.
you.
Good night.
Good
yeah,
night.
big. Let me also put on record big thanks to the INTAS field team also, because
Yes.
of which maybe the program is brought to so many physicians across the country. Thank you very much.
Thank you,
A
sir.
very
Thank you,
good
sir.
night to all of you.
Thank you,
Thank you.
sir. Thank you.